Thank you, Emily. Welcome everyone to the Society of Advanced Bronchoscopy webinar series. Your host today, Husam Nayef. We present to you discussions and reviews in advanced bronchoscopy and interventional pulmonology. Today, we have an exciting topic, post-lung transplant complications. We have Dr. Kumar, who is the medical director of the lung transplantation program at the University of Minnesota Medical Center and an associate professor of the medicine in the division Pulmonary Allergy and Critical Care Medicine. He also holds the Judith and John Murphy Professorship of Advanced Lung Disease at the University of Minnesota. His expertise includes lung transplantation, interstitial lung diseases, and rare lung disorders. Dr. Kumar has made significant contributions to the field through original research and peer-reviewed publications, and editorial roles for textbooks and medical journals. He's also a frequent speaker at the national conferences, including CHEST and ATS, where he presents on topics in pulmonary and critical care medicine. Without further ado, Dr. Kumar.
Thank you, Husam. Thank you to the Society of Advanced Bronchoscopy for inviting me to do this talk. It is indeed an honor, and it's actually my pleasure to be here. And without further delay, I'll get started, and we'll be talking about airway complications in lung transplantation, the challenges, what are some of the clues, and what are some of the solutions. Now, when it comes to solutions, you guys as at least some of you as advanced bronchoscopists, some of you may have experience taking care of lung transplant patients, will be a little bit more familiar. What I would want you to take away from the talk is that the management of these patients when they have problems is a very coordinated effort, and that's what leads to optimal outcomes for these patients. So these are my disclosures. So briefly about the history of lung transplant, the first successful lung transplant rather, was performed way back in 1963 at the University of Mississippi by Dr. James Hardy. And the recipient was actually a 58-year-old gentleman. He actually had malignant lung cancer. He died 18 days later, but his death, contrary to what people thought was a failure of lung transplant, the organ rejection, his death was indeed from renal failure, and his general debility because of his extensive left lung and thoracic wall malignancy. The interesting thing is that when they actually looked at the pathology, the autopsy, the lung itself exhibited only very minor evidence of rejection. So that was one of the first indications that this is doable. And then in the next 20 years or so, really about 30 to 40 transplants were performed or attempted in several parts of the world. Most of the recipients live for a handful of days, but one of the main obstacles during this period was actually the poor healing of the airway anastomosis, that connection between the donor and the recipient lung. But nowadays we perform about anywhere from 3,500 to 4,000 lung transplants per year across the world, and the numbers continue to increase. So let me tell you a little bit about what happens during lung transplantation. And this is important when you think about the problems these patients have in the airway. So just a brief anatomy reminder is that the bronchus has a dual blood circulation. So it's primarily a bronchial artery circulation, which is the richly oxygenated blood that comes from the originating from the descending aorta that gets about 2% of the cardiac output actually. And that, along with the pulmonary artery, which is actually poorly oxygenated blood, forms this submucosal plexus around the airways. When the transplant happens, this airway is the bronchial artery circulation is transected. The bronchial artery circulation is in fact not restored in the donor at the time of transplant. So that initial few weeks, the airways are dependent on the retrograde blood flow from the pulmonary vessels, which, as I said before, is actually poorly oxygenated blood. Sorry about that. And that first few weeks, it indeed is very vulnerable to problems related to ischemia. And it takes really about a few weeks for the bronchial artery microvessels to slowly grow over the anastomosis lines and to restore some sort of a meaningful circulation. So that period, the first few weeks, is a period of airway ischemia, and that sets up the airways for problems immediately and in the future. So that's a key point here, because that understanding is related to our knowledge of what happens to these airways. Now, historically, what 20, 30 years ago, 40 years ago, people attempted different things to try and mitigate this problem. So initially it was thought that, well, a lot of steroids are causing problems, so people discontinued steroids, but then they understood that without steroids, the lungs will get rejected. This is actually an interesting picture. You can see some yellow lines there, which is in fact, folks were taking omentum from the abdomen and wrapping around the airways, the whole idea being to get some circulation in those anastomotic areas. So those yellow lines are actually dye that is injected that shows microvascularization, and that was attempted for a while, and then it quickly lost interest because the outcomes were not that great. And then people tried a lot of different things like intercostal muscle flaps, pericardial fat pads, telescoping of airways, which was in vogue for a while, and then long-term outcomes of that also were not particularly attractive, so that was abandoned as well. And then in the near future, some important surgical techniques were attempted, which were successful in bringing down the incidence of airway problems, particularly the short donor bronchus, where only about 1 to 2 rings proximal to the secondary carina and a longer recipient bronchus was used, so that you're reducing the amount of donor bronchus, the length of donor bronchus, so that you're not attaching an ischemic area and increasing the risk of ischemia in that particular area. So a shorter donor bronchus, some studies actually showed that outcomes are very good with this particular approach. Various suturing techniques were tried, and another technique that is attempted at some institutions, although not everywhere, is the concept of actually revascularizing the bronchial artery. And again, not widely popular because the surgery can be cumbersome, painstaking, long, although some studies have shown that doing the bronchial artery revascularization may improve outcomes, yet it's not widely adopted. So a brief overview of the incidence and timeline of airway issues. Early on, the most common airway issues include airway ischemia, that is a sloughing of airways, and a spectrum of that includes airway ischemia extending to airway necrosis and finally dehiscence. Now that's early, and then as a result of prolonged ischemia, later on, these airways can develop bronchial stenosis, vanishing airway syndrome. Sometimes the granulation tissue can be too proliferative, and that can cause exophytic granulation tissue, and that can actually obliterate the airway lumen. So the incidence and timeline of airway issues is variable. Early on, you tend to have more ischemic problems, and later on, you have the sequelae of the early airway ischemia. So the overall incidence of anastomotic airway complications varies anywhere from 2 to about 30%. It was much more about 30, 40 years ago. It tends to be not as common these days, yet something when it happens, very important for people taking care of the patient to recognize. So what are the risk factors? Some have been identified without going into detail about each of them. From the donor side, if there is a size mismatch, or if the donor has been mechanically ventilated for too long, more than 50 hours, that's a risk factor. We'll look at some recipient factors in the next few slides. Right side transplant tends to be more, the right anastomosis tends to be more prone to airway problems compared to the left side. And even the organ preservation choice, even the choice of perfusate has been considered to have some contribution to the risk for airway ischemia. And folks have studied this. Is actually a publication from 2016 in the Journal of Heart-Lung Transplant, where you can see that the recipient age, male sex, the pre-transplant diagnosis of idiopathic pulmonary fibrosis, bilateral transplant, so there is increased ischemic times there. If a patient is actually hospitalized, particularly if they are hospitalized in the ICU, these are risk factors for developing airway problems. In a more recent study that was also published in Journal of Heart-Lung Transplant, this is actually a meta-analysis, about 52,000 patients, and they actually found that a lot of this is common with what was identified before, that male sex, but in this particular study, a diagnosis of COPD was found as a risk factor. Postoperative infection, about 3.5-fold increased odds of developing airway problems. Now, if you look at the operative factors, a recipient that was mechanically ventilated is at about 1.5-fold increased risk of airway problems. But if they have been on ECMO, for example, that's considered as protective or lower risk. So these are some of the recipient factors that have been identified in general. If the recipients are men, history of short telomere syndrome, they can have healing problems, history of rejections after transplant. If they're post-transplant, early first 2 or 3 days is complicated by primary graft dysfunction. If they have an immunosuppression before transplant, these are all risk factors. And of course, the amount of time they spend on mechanical ventilation after transplant is also a risk factor for developing airway problems because of the impact of positive pressure. Now, why is this important? Because generally these patients who have airway problems tend to have a poor quality of life. Early airway ischemia in most of these patients resolves, but in about 20% of these patients, it goes on to have serious problems. So they tend to have more infections, it is bacterial infections, particularly fungal infections. That area of ischemia can be nidus for fungal infections, particularly aspergillus. But if they have airway stenosis or airway necrosis and dehiscence problems, then the first in a few months, particularly that the first year, they are getting multiple bronchoscopies, particularly patients with airway stenosis. They get frequent dilatations, debridements, cryotherapy. So some of these patients get every 2 weeks bronchoscopies or every monthly. And so it does set them up for a poor quality of life early on. In very advanced cases, they may even require surgical procedures, which we try to avoid, such as sleeve resection, lobectomy, and extremely rarely retransplantation. And overall, these patients tend to have worse survival, as I'll be showing in some of the studies that were done subsequently. Some of you might be familiar with the International Society Heart-Lung Transplants airway grading system. This is adopted for classification of airway abnormalities for post-lung transplant patients. This iteration was published in 2018. Early on, the grading system was a more basic one. It was called the Courant's grading system, which was very basic, which is very subjective. And the drawback of that system really was that it was very subjective, as I said, but it was only also talking about the extent of airway ischemia, and it was really not talking about some of the later complications such as stenosis and malacia, for example. And there were a few other versions that have come about, but this is the most recent airway grading system that's probably widely adopted. And it really looks at few of the different abnormalities. So it looks for evidence of ischemia and necrosis, and we're going to dissect this one by one. It looks for evidence of dehiscence. It looks for stenosis, and then it looks for any evidence of malacia. And then it comes up with a grading system. So let's look at some of these. So this is what the airways kind of look like early on. So the picture on the left is what we all like it to look like. So that's the normal appearing airways. But for some patients, like the picture in the middle, you can start seeing some perianastomotic ischemia. And again, that's when we start paying attention to these airways with, frequent bronchoscopies. And for some people, at the end of the spectrum, you develop the necrosis, which is really what we don't like to see. Basically, ischemia necrosis is a very early problem. And on the mucosal side, what you're really seeing is edema, hyperemia, and mucosal stuffing. And as it becomes necrotic for some patients, then you start seeing gray or black devitalized tissue. And it can also involve the deep malaise, which is when it becomes problematic. And this is a classification system, and we look at some of the examples. So this is actually one of my patients. She's a 46-year-old female. She was transplanted maybe 6 weeks ago. She had myositis, interstitial lung disease. So this is a bronchoscopy picture 10 days post a bilateral lung transplant. And I think you can appreciate these yellow areas. This is the anastomosis. This is actually the distal parts of the distal airways. And this is a left anastomosis. So this, for example, would be a person with perianastomotic ischemia. So would be, A, you don't really see any extension from the anastomosis to major airways yet. And as far as the extent is probably less than 50% circumferential ischemia. So this person's classification would be, for location would be A, and for extent it would be A as well. And so that's ischemia because this person does not have necrosis. Now, this is another example. This was also someone who we transplanted early this year. It's a 64-year-old male who's a right single lung transplant. And this is the bronchoscopic appearance 2 weeks after transplant. So you can see there is more stenosis, there's more ischemia here. And it is perianastomotic, but it's not confined to the perianastomotic areas. These are the distal airways, so it's definitely extending into the distal airways. It's kind of hard to say from the picture if it's actually all the way to the lobar and segmental airways, but that doesn't look like it. So we'd probably call this about B, so it's extending more than 1 centimeter from anastomosis to major airways, certainly extending into the BI. And as far as extent is concerned, it's actually 50 to 100%. You don't really see evidence of necrosis yet, although you may start seeing some early necrosis. You are starting to see some evidence of gray or deep vitreous tissue, but it's probably mostly ischemic. And in some extreme cases, this is what it would look like. These are pictures from the heart lung transplant journal. This is a very advanced case where you can see that the airway ischemia and actually necrosis is obviously more than 1 centimeter from the anastomosis. It's definitely extending into the BI. And there is necrosis actually. This is gone from ischemia to necrosis, affecting up to 50 to 100% of the airways. And this is also a very advanced case where again, it's more than 1 centimeter from anastomosis, but this time it's actually extending into the lobar or segmental airways. And again, 50 to 100% of the anastomosis airways are involved. So that's a spectrum of airway ischemia to necrosis that you see. The next thing that we really dread about and that we really hope not to see is airway dehiscence. And again, it's at the end of the spectrum. So ischemia, necrosis, causing dehiscence. And basically, it's a full thickness separation of the airway. Generally occurs about a month or 2 after transplant. Bronchoscopy is a gold standard diagnosis, but if you're at the bedside, taking care of the patient, or let's say you're covering, really the patient's present with 1 or 2 of the following. It's a persistent pneumothorax or a persistent pneumomediastinum, or a new pneumothorax or a pneumomediastinum, or let's say they have a chest tube, and then you're finding that they have a continuous air leak. So that's kind of what clues you into dehiscence. And the key thing to know is that it is a very high mortality problem. And you can see here, for example, the picture at the top is actually for example, the dehiscence is classified as cartilaginous, membranous, or both. So this would be a cartilaginous dehiscence. This is a small one and probably is going to heal on its own, and we really don't have to do anything other than frequent monitoring and make sure that if there is an infection that gets treated. And then you also have this here, which looks very ugly, and that is actually a membranous type of dehiscence. And this probably requires intervention. Again, you look at the extent of the dehiscence as well, but really most of what we care about for dehiscence is it yes or no? Is it there? If so, what do we do about it? This is actually a real life example, 64-year-old male. I'll take you through a case of someone with serious dehiscence who we thought will be a mortality. Basically, he had a bilateral lung transplant for IPF. He has history of pulmonary hypertension. This is actually his airways post-op day 5, and it's not a very clear picture, but I think you can appreciate some onset of ischemia. Now, as a person who does these bronchoscopies often, when you see this airway post-op day 5, you really don't worry too much about it. You know that there is an ischemia, you have to pay attention to it, but that's about it. Now, unfortunately for this gentleman, he stayed on the ventilator for a very long time. I think he had a tracheostomy too, and he had a persistent air leak, and by post-op day 21, he was starting to look real sepsis with no obvious source. There was an air leak, and we did a bronchoscopy by the 3rd week, and we noticed that his ischemia has now increased. So it's become perianastomotic. You can see some gray deep vitreous tissue distally extending into the BI, and you can see this obvious defect there. That's a cartilaginous and probably membranous dehiscence as well. So that was promptly diagnosed, and interventional pulmonary got involved. This is actually a picture from their bronchoscopy. There is a BI fistula. That's at the 4th week mark. And because he was not doing well, conservative management was not, generally though these patients, if they're not that sick, we do wait and see if it gets better, but this was too big of a defect and causing air leak and concern for empyema, so we had to try and close it. So in this particular patient, an ultraflex bare metal stent was placed into the right mainstem bronchus into the proximal PI. The attempt was to close off the fistula, and it was challenging. They did multiple bronchoscopies, and as with these patients with airway stents, this person also had the problem with a significant amount of mucus, so had frequent bronchoscopies and suctioning. And actually, after a while, and really there were, he also had a chest tube that was making sure that the lungs remained well expanded. He was on multiple antibiotics and antifungal as well. At the 6-month mark, eventually the stents came out, and that area of dehiscence actually healed completely. This was a CT scan. So May of 2024 means this was a CT scan at the 3-month mark. You can actually see the stent and the connection. So he actually had a bronchopleural fistula. So this was the sagittal and the coronal views. And this is actually his CT scan right now, which is February 2025. He's actually doing extremely well. So he actually had a hydropneumothorax for a long, long time. We basically just drained it out, took out the catheter, antibiotics, airway exams, and he's doing really well right now. This was a story with actually a happy conclusion, but dehiscence is a high mortality problem. So not all patients will have actually a good ending. Now, moving on to airway stenosis, important thing to realize that it is actually the most common airway complication, but you won't see that in the first 4 weeks because it is a sequelae of airway ischemia. And patients manifest with shortness of breath, could be with exertion, episodes of wheezing, really having a hard time, sometimes coughing out the phlegm. And most of the times, the airway stenosis, as a classification he will show, is anastomotic. But sometimes it can be non-anastomotic as well. It can happen in the distal airways, particularly in the bronchus intermedius. In fact, there is a rare condition called vanishing bronchus intermedius syndrome. It is rare, but the outcomes are not good. But fortunately, most of the stenosis happens in the anastomotic area, and it's because of the airway ischemia, like I talked about. So this is actually an example. This is another patient who's 69. He had bilateral lung transplant in October 2024. And he was doing great. He was actually staying locally. He was from far away and getting ready to go back home. And then at the 3-month visit onwards, he really started experiencing some shortness of breath. It was really non-specific. This is his spirometry. And you can see that, so his transplant was October of 2024. If you look at his FEV1, it went all the way up to 3.05. This was his flow volume curve. And then the January visit, it dropped quite significantly from 3 liters to 2.4 liters. And we started getting concerned. So, of course, for a lot of these patients, the key to remember is your chest X-ray can be completely normal. CT scans can be valuable. It can also be valuable for planning the procedures, like especially if you have a 3D reconstruction, you can sort of figure out the anatomic parts of the airways and helps with planning as well. But X-rays are almost always normal in these patients, and this was actually his bronchoscopy image. So you can see some mild left mainstem stenosis. Now the proceduralist at this time did not really feel like it was causing too much problems, and rightfully so. Balloon dilatation was performed, and he grew, I think, Pseudomonas, so he was treated with antibiotics, but we also put him on some steroids. And he really did not feel much different. I mean, I think maybe a couple of days he felt okay. And then he came back to us 2 weeks later with significant wheezing. FEV1 dropped again. We put him through another bronchoscopy, and look at the difference in the airway lumen now. So that has progressed significantly. These bumps here are just exophageal granulation tissue, which most of the times is expected. Generally, nothing much is done about it. And so because of this significant stenosis, and he also had to go through another kind of urgent vascular surgery, the interventional pulmonology team here put in actually a silicone stent, cleaned out the airways, and then he felt much, much better. He was readmitted about 2 weeks later with shortness of breath, and he was found, and he was not really doing so well with airway clearance, with like saline and all that. And then he was found to have a completely occluded silicone stent that was taken out, cleaned out, and a metallic stent, a covered metallic stent, I think a hybrid metallic stent was actually placed, and then he felt much better. He continues to do quite well. So that's airway stenosis. Generally for airway stenosis, if it is mild, it's observed. If they become symptomatic, almost always the first attempt is just to do balloon dilatation. It's rare to go to a stent right away. So balloon dilatation or rigid bronch dilatation based on the preference of the proceduralist, and often serial balloon dilatation itself may suffice. The problem with balloon dilatation, of course, is that it can recur. So you may need multiple dilatations. And if it's in serious cases, a stent is considered. Often it's a silicone stent or I guess some of those third generation hybrid stents, the covered metallic stents can be used as well. But generally balloon dilatations and conservative management is done. And in most of these cases, the stents do eventually come out as well. So moving on to the other type of airway problem is a tracheobronchomalacia, which is actually, as most of you know, is a dynamic reduction of the cross-sectional area of the airway, mostly significant when it's more than 50% reduction during expiration. The underlying pathophysiology is a loss of cartilaginous support, and these patients can be, it can be a very frustrating problem. These patients can be quite symptomatic, particularly if they have a heavy BMI. They get shorter breaths with exertion. They kind of have this barking seal-like cough. They may have frequent infections and actually difficulty clearing infections as well. And again, there is a classification where you look based on the location, if it's perianastomodic or if it's diffuse. The management of this problem is generally conservative and also depends on the degree of symptoms. If they're asymptomatic or mildly symptomatic, often just airway clearance, weight reduction is attempted. But if they are quite symptomatic, airway splinting with the CPAP therapy can be tried. Extremely rarely endobronchial silicone stenting can be tried. And very, very rarely are these patients candidates for surgery, which we almost never try to refer them for that. And so these are images of actually a patient, 65-year-old female, who actually had significant tracheobronchomalacia after right lung transplantation. You can see how collapsed and narrow the right mainstem bronchus looks like in expiration. So why do we care about airway complications? What is the impact, right? Why do we do frequent bronchoscopies? Why do we coordinate with our interventional pulmonary colleagues? Because it affects survival. It affects not only just short-term outcomes and quality of life, as I said about before, but it also has a long-term bearing. And this was the UNOS database study from 2016, which showed that if you look at 90-day, 1-year, 3-year, 5-year survival, patients with airway complications have a worse survival. In this particular study, they only identified about 1.4% patients actually who had airway complications. But remember, this was self-reported or reported by centers, and so there is significant variability. But regardless, those transplant recipients who have airway complications. Now, remember, these airway complications comprises all types of airway complications like stenosis, necrosis, dehiscence, bronchomalacia, but probably bulk of the mortality comes from those patients who have actually airway dehiscence problems. In a recent study, which was actually a meta-analysis, I think I alluded to this study before, they looked at about 52,000 patients, multiple studies. The pooled incidence of airway complications was about 12%. And again, airway complications related to mortality was quite significant. If you look at the 1-year mortality, now this is not survival, mortality, at the 1 year was about 23%. At the 5 years, that's about 66%. So clearly had an inferior survival, and no surprises if you have airway dehiscence, which leads to bronchopleural fistula and mediastinitis and pneumonias and empyemas and all that, that can have a very high mortality, 30 days up to 60%. This was actually a study that I was also part of that was led by one of my colleagues, Dr. Lee. Basically a single center analysis of the risk factors, incidence, and outcomes of clinically significant airway obstruction, which was defined as, on that ISHLD grading, having an ischemia more than B2, stenosis more than 50%, and presence of dehiscence. The limitation, of course, is these were based on review of bronchoscopy pictures, so there is some subjectivity to that. But in any case, no surprises. Patients who have clinically significant airway ischemia actually had inferior outcomes. One of the proposals that we had come up with is to kind of come up with a more practical adaptive grading system. If you look at the ISHLD grading system, is very detailed, but that can also be very cumbersome. So this new proposal of an adapted grading system was more focused on let's look at ischemia necrosis, which is really what we care about the most early on. And then when it comes to dehiscence and stenosis, what really matters is if it's there or not. And so that was one of the proposals. And when it comes to management of these patients, aside from the bronchoscopy interventions that you will be called in for, a lot of these patients early on are on mechanical ventilation. There are things that the ICU teams should be doing. So very important to stick with the basics. So that would be your lung protective mechanical ventilation, low tidal volumes, avoidance of paratrauma, keeping the PEEP at reasonable rates, 5 to 8 to up to 10 probably. Higher PEEPs than that could be problematic. And then, making sure that our patients are not, excessively hypoxemic or very hypercapnic, which can cause pulmonary vasoconstriction. And always looking for an opportunity to make sure that we are trying to extubate these patients and really minimizing the number of days they are subjected to positive pressure ventilation. And along with that, we look for almost all these patients. Some of you must be familiar, they're on empiric antibiotics early on, but we are also targeting antibiotics based on the microbiology. Majority of transplant centers place these patients on inhaled amphotericin B, and that's to make sure that this area of anastomosis, which is, as I said before, very vulnerable to ischemia, is not getting deposited with aspergillus. Some centers also use systemic antifungal therapy concurrently. We make sure that these patients are not profoundly hypotensive or in shock, because that can also compromise blood flow to that area. Make sure that these patients are fed very well, so adequate nutrition. Acute kidney injury is a known risk factor for airway ischemia, and so prevention of acute kidney injury, and paying attention to immunosuppression. These patients are on standard immunosuppression. I specifically indicated no mTOR. mTOR inhibitors are the class of medications that essentially sirolimus and everolimus. These agents are not to be used for the first 3 months, because studies clearly showed that these agents affect wound healing, and patients who are on these agents actually are at higher risk for airway dehiscence. And so these are some of the conservative and ICU measures that need to happen concurrently, along with bronchoscopic management and sometimes just watchful monitoring. So in conclusion, the takeaway message here is that airway ischemia happens in lung transplant, and it's a primary cause of both immediate and delayed complications. The risk factors for these can be donor-related, recipient-related, and surgical-related, and we have made some headway, particularly from the surgical side in the last 20, 30 years, as far as mitigating the risk of airway ischemia, but it's still a problem, a clinically significant problem that has the potential to lower the survival for transplant recipients. Now, the issues that you will run into mostly early on includes issues with necrosis and dehiscence in extreme cases, which is a serious problem. But later on, these patients can get airway stenosis, tracheobronchomalacia. And what I would suggest is the management, as I said, is really a team effort. It's a coordinated effort between interventional pulmonology, transplant pulmonology, critical care, and cardiothoracic. Cardiothoracic interventions are reserved for extreme cases. That includes like surgical repair or sleeve resections or retransplant, and we try not to get there, but in some cases that is required. In most cases, it's just medical management and conservative measures. So with that, I'll stop my presentation and I'll just see if we have any questions. I think we have a lot of time for
yes. Thank you so much, Dr. Kumar. That was very comprehensive and detailed. I like all the updated guidelines that you had cited. So I think for the first question, I will take that one. You talked a lot about what are the risk factors, and I think what are the components that participate into this wide range of complications. So it's a two-part question. One is, why do you think there is a different or a wide range of complication rate reported? And the other question is, which is, it's more of the bulk of the lecture that you just gave is, what is the most integral component that you think really clinically has the most value,
Yeah.
and what ways you guys do at Minnesota that mitigate this, this
Yeah.
whatever it is, so.
Yeah. So the wide variability, I think I mentioned, some papers are like 2%, some papers up to 30%. It's definitely because of the subjectivity of this. There is obviously, as I said, some of it is self-reported. Some of this is based on looking at bronchoscopic images, so it's a retrospective assessment. And it's only in the last, I would say, I mean, the ISHLT is airway grading system, the systematic way of really, reporting this, it's been around really for the last 6-7 years. So prior to that, it was just people would say it's there, and again, whether it's like extending into the distal airways or not, and whether it's confined to the perianastomosis, a lot of this is sometimes lacking even in documentation. So I think the wide variation is because of just how it's been reported. We know that studies early on did study, pay a lot of attention to airway complications, because that was indeed the Achilles heel of lung transplant during those days. And we know that the surgical techniques and our knowledge of early interventions and monitoring and things like that have improved the incidence of airway complications. So I think that is why you have this wide variability. I suspect if you look at it this day and age, or maybe in the next 5 to 10 years, you will probably have a better idea of what is the quantum of the problem we're dealing with. Yeah, as far as the interventions that make the most difference, I think it's a combination of different things. I think we have understood that sometimes being conservative and watch for monitoring and treatment of infections and treating the fungus, for example, is important. But along with that, the early adoption of or coordination with interventional pulmonology is key, especially for patients with necrosis and dehiscence, because these patients need prompt interventions. Because once the chest cavity is soiled and there is infections, then it's a whole different story. The mortality is high, and it's never easy to take these patients for surgery. So I think it's a combination of knowledge of the problem, early recognition, studies that have been performed, and just better techniques available in general with even bronchoscopy that has made a difference.
Excellent. Which is a segue for another question. How often do you bronch, and what's your protocol?
So every post-transplant patient gets a bronchoscopy, within the first couple of days for sure. The practice is different across different centers, I can tell you. Some places do a bronchoscopy right away. Most of these patients would have had a sort of a basic bronchoscopy in the operating room right before they are coming to the ICU and gets dropped off in the ICU by the surgeons. But our pulmonologists will do a bronchoscopy generally in the first 24 hours, or definitely within the first couple of days. Now, after that, bronchoscopies are as needed. A majority of these patients do get extubated in the first 3 to 4 days. So then after that, bronchoscopy is very dependent on how they're doing. At our center here, we do have a protocol where these patients do get an airway exam at least once or twice before they are discharged from the hospital, but not every center may do that. But they will. But if you have a heightened, threshold, or let's say you are assessing and you're finding that there is in fact airway ischemia, you are considering that there might be some necrosis coming through, and certainly if you're wondering there is dehiscence, then these patients will get bronchoscopies more often, once or twice a week.
That's it. Thank you so much. Another question, how quickly do you advance to stent instead of repeat balloon dilation for anastomotic dehiscence?
How quickly do we consider a stent after balloon dilatation? Yeah, very subjective. It is, we discuss with our interventional pulmonary colleagues, obviously, but the preference is almost always to not use a stent unless we absolutely have to. So we always go with balloon dilatation. So if someone's moderately symptomatic, mildly symptomatic, they're outpatients, they're doing quite okay, serial balloon dilatations or rigid dilatations are performed. If they have very severe stenosis, that the balloon dilatation, the effect of that is not lasting long enough, right? Like they're coming back every week, they're symptomatic, we know that the balloon dilatations are not going to last that long, then often they'll get a balloon dilatation followed by a stent placement. So that is generally what we do for airway stenosis.
Mm. And I'm assuming, bare metal stents to allow for more granulation tissue is the standard.
Exactly. For the neopigmentation is, especially I think these days you have new stents, so it's better, is what I've heard from the colleagues, from the IP colleagues. So that's generally what can be used. But silicone stents are used for airway stenosis, as I was showing in that particular case as well. The problem with the silicone stent, of course, is not generally preferred for patients. It's not used for patients with the airway dehiscence because of the concern that it doesn't cause neoepithelialization. It can actually enlarge the defect even more. But yeah, balloon dilatation is generally what we go with, or is what I've seen at our center for airway stenosis.
Yeah. Second, third, fourth question, I guess. What's your opinion on using heat modalities, laser/APC, in management of post-transplant airway stenosis?
I think there is a role, particularly for the, I guess, where I've seen it used quite often is also if they have a very hyperplastic or exophageal granulation tissue, for example, laser therapy, APC, cryotherapy. I know that some of our interventional pulmonary colleagues here use is a liquid nitrogen with true freeze cryospray. Yeah, true freeze cryospray. They use it, and I think the few folks that I've spoken to in our group here, they seem to be seeing good benefit with that. I know that not everybody uses that. I think it's more popular in GI, but people do use it for a true freeze cryospray as well. So laser, APC, cryotherapy, and true freeze, I think our colleagues use almost all of that. Some centers also use like mitomycin steroid injections. I think that's extrapolated from ENT literature, where there is, I think, more data for benefit. But some centers do use it, and anecdotally, I've seen that also delay the recurrence of stenosis. Although I cannot say that that's universal. So a wide variety of other modalities also are used by some by our colleagues here, but I'm sure that some other centers also using all of these.
Yeah, from an IP perspective or an IP hat, I think there is definitely more folks are leaning toward the ice therapy with the cryospray specifically, even though it has a lot of potential complications and perforations and things like that. And you're right about the benign subglottic stenosis data. We use the submucosal injection, and there has been some centers that use that. But the cryospray has taken a lot of heat, I guess.
Do you use that a lot in your practice too, Husam?
I actually don't use cryospray, but I have talked with we talked offline about USC, and I know for sure that Dr. Fry from Utah, who's a transplant IP pulmonologist, have mentioned in a couple of webinars that she uses it, and I think she's a big propensity for using a cryospray. I think the data is definitely still very young and early to really say that this is the modality, but I think there's a shift towards the ice therapy, specifically the spray part. Yeah, from what I can see so far, at least anecdotally users. Yeah,
and I must say that this is the first place where I've seen it used in Minnesota. And I have not seen anything adverse, at least. I've had some instances when my own IP colleagues have said, in this particular case, it did not really work. But I've also seen some instances where they have said that it has done a good job. So I suppose more data will help, like for everything.
Yeah. So we have a couple more questions. Sorry, but why is there a different type of complications based on centers? What's the uniqueness of center-based complications?
Yeah, that's an interesting question. I think so. Every center has a different philosophy when it comes to who is a. Remember, the outcome of transplant depends on a multitude of factors. It depends on the recipient, of course, the most perhaps, but equally importantly are several other factors such as the donor, the ICU management, and then there is this whole box of things that we are uncertain about. That we don't know till the new organ is implanted into the recipient. We don't really know how that recipient is going to behave. Like how are they going to respond to immunosuppression? There's a whole lot of things that are unknown to us before someone goes to transplant. But in general, every center has a different threshold for who is considered a candidate. Some centers are conservative, very conservative, as far as they should have single organ problem, they should only have a lung problem, they should be an ideal candidate outside of the lung, they should not have heart disease, liver disease, they should be younger. Age is a criteria. We know that younger patients tend to do well with transplant. Some centers do not. Some centers are okay with taking on more complex patients with coronary artery disease who require bypass surgery, for example. Like we at our center, we perform that. Patients with some degree of kidney problems, older patients, our age cutoff is 75, for example. Some centers do not offer transplants to patients above the age of 70, for example, or 65. And all of that factor into outcomes. But one of my mentors used to say that our ability to predict outcomes for a recipient is probably about 50% accurate. I mean, there are times when we say that, oh, this is a perfect candidate, and that person is a person who runs into complications and has a rough course, can die, that we would not expect. But there are patients who we feel like, oh, does this person have a grit to go through it? I mean, they have some CAD, they have some CKD. Are they going to really do it? And they go through it and they get out of the hospital very quickly. So there is that, that unknown factor for transplant. And I think, but in general, if you look at it, the candidate selection, plays a big role, as does donor selection, ICU management. Is a lot of different factors.
Mm-hmm. Yeah. Yeah, it sounds like a multitude of factors, and I think there is variability between each center that creates this unique complication. So maybe everybody could use some knowledge from other centers and see what they're doing right, So we have 3 more questions, and in the setting of bronchial anastomotic dehiscence associated with persistent air leak, what is the recommended duration of conservative management before considering intervention, and what is regarded as the optimal timing for endobronchial stent placement? I think it's very similar to that first question. You already, but take it again. So
yeah. So again, a lot of it depends on how sick the patient is. I think the picture that I showed, for example, if it's a cartilaginous dehiscence, it's not really causing air leak. We don't do anything. We just monitor. We do bronchoscopy every few days, make sure that it's not like a gaping wound, or it's enlarging. Whereas if you have someone who has a significant dehiscence that is now tearing down through the mucosa, it's definitely soiling the airways, soiling the pleural space, for example, that is a problem. And if that patient is early on, they are so immunosuppressed as well, that patient is probably going to have sepsis, septic shock. And so that's an indication where you would act right away to consider good airway clearance, but probably even placement of a stent. Now, stent comes with its own fair share of problems, right? But you evaluate the risk and benefits of, okay, if I don't place a stent, what's going to happen? If I place a stent, what's going to happen? If it's a very minor defect, there's a little bit of an infection or an empyema, minor air leak, it's an intermittent air leak, the microbiology, you know what you're treating. Maybe it's okay to wait. I mean, if it's a small defect, you can treat with antibiotics, do serial bronchoscopies, wait and watch. But if it's someone who has like an empyema or like a continuous air leak, is hypoxic, is not doing well, and you really don't know, what the trajectory is going to be, that's probably a high mortality situation. That's a situation where we probably would not delay consideration of a stent placement. And interventional bronchoscopies are very good about, not only just putting these stents on. I think they are all very mindful of the fact that stents also come with problems. And so they are very good about frequently taking a look, cleaning out the stents, making sure it's not getting, plugged up, but also even try and take it out. They always try to take it out of probably the 4th to 6th week mark. And so they don't try to keep it on there for a longer periods of time unless they absolutely have to. But it really depends on the patient is the answer,
Yeah. And I think, the symptoms, I think that, and where is the patient? I think those are the, factors, like you said, are crucial. And if you think the risks outweigh the benefits of stenting versus just balloon dilation.
Right.
Could you touch base on the role of medication management in prevention and treatment, antifungal nebulized treatment?
Yeah.
I think you already mentioned a little bit about amphotericin B and the antifungal part. Yeah.
Remember that the donor lungs that we get, these are mostly brain dead donors. They've been on the ventilator for a few days. And so almost all of them have had some sort of, aspiration lung injury. We never get perfect lungs. Almost all of them, they're growing some sort of, Pseudomonas or Staph aureus or something. So we are getting contaminated lungs and we're putting it in recipients, and then we are immunosuppressing them very heavily. So that puts them at risk of pneumonia. Pneumonia is the most common, reason for death within the first, month as well, probably the most common pulmonary complication as well. Now, when it comes to airways, infections, treating infections, controlling infections is paramount, because that area of ischemia itself makes that area vulnerable because there's no blood flow there. So it's an easy nidus for bacterial infections, fungal infections. So it's fairly 100% of the transplant programs have an empiric antibiotic regimen, which sometimes goes for 40 to 72 hours. Some do it for 7 days. We will do bronchoscopies, as I said, the first day itself. You get the microbiology back and you put them on antibiotics specific to the microbiology. The other microbe that is of very key importance is the Aspergillus. And that's because Aspergillus can really stick onto those airways that are ischemic. And so nearly 100% of the programs will use nebulized form of amphotericin B. And the whole idea is to make sure that it's preventing the deposition of Aspergillus in that area, because once Aspergillus stick there, it can cause Aspergillus tracheobronchitis, but it can also cause dehiscence. It can cause invasive aspergillosis, which is about 50% mortality at least. It's very hard to clear. And so we pay a lot of attention to controlling the infections and making sure that the airways are as clean as possible with antibacterials and antifungal, both nebulized and systemic sometimes. And that is very important. That goes concurrently with the rest of the things we do.
Yeah, great. Thank you so much. I think the last question I'll take on, and we'll close off this awesome session. It's funny that you mentioned the first transplanted lung, which was for lung cancer, because we have recently seen a lung transplantation for lung cancer, and I'm wondering what is your take on the case? And the other question is, are we shooting ourselves in the foot by maybe taking people that shouldn't be taken, or is this really the new trajectory of how we're gonna maybe expand the world of transplant? And I know this is maybe a little bit off topic, but I was wondering, since we have you on this webinar platform, what's your take on all this new stuff and ex vivo lung and the ice lung, or all this kind of new things? What's your take?
Yeah. So number one, lung cancer being treated by transplantation. I think Chicago has one of the centers that actually has a trial for lung cancer treatment with lung transplantation. Historically, transplant was reserved for a specific type of lung cancer, the BAC, what's historically known as a BAC, bronchoalveolar cancer. And that constituted a significant minority of the transplants that were performed. It's been done for patients who had the BAC that was entirely confined to the lung with no evidence of metastasis, a very handful selected group of patients, and the outcomes were mixed, but there is some interest in some centers to sort of protocolize and see if some of these patients actually would benefit more from lung transplant than just being treated with chemotherapy and all that. And I think that's the kind of study protocol that the center in Chicago has. I think it's very early for us to say what it's going to look like. What is the, all of what we're going to learn is really about long-term survival, long-term data, right? So I think I'm still on the fence about cancer patients getting transplants, but I think perhaps there is a very well-defined minority group of patients who may benefit from it. But I think the jury's out on that. So that's one. The second is the ex vivo lung perfusion. There is a lot of innovation in this field, and it's a very exciting time to be. The whole concept of ex vivo lung perfusion, and even there's new technology called called by a company called Paragonics and all that, where they basically, it allows us to, number one, with ex vivo lung perfusion, really work on lungs that are not that are probably marginal, or what we call as extended criteria to begin with. And if you discard those lungs, then they're gone. Then you have recipients that are waiting for transplant who have waitlist mortality. With the ex vivo technology, the concept is that you work on these lungs, and over a period of time, you prime them and make them better with the gas exchange and oxygenation. And there is definitely some data to suggest that these lungs on ex vivo lung perfusion can be used for transplantation safely, and the outcomes are not inferior compared to lungs that are not on ex vivo, for example. The relatively newer things that are happening include, the Paragonics technology, as I was talking about, and full disclosure, I have no conflict of interest with them. But the whole technology means that you're able to transport these lungs, protect them from the vagaries of thermal injury and pressure changes, because historically when lungs are transported on ice, there are different temperature points when in that organ. Not every part of the lung is is protected by the same temperature. So now with the temperature control systems and pressure control system, you are essentially mitigating the effects of swings in temperature and swings in pressure. And so that has shown definitely some promising data that's been presented at national and international meetings. And we as a center, we are using that as well. So it's major innovation that is probably a long road ahead before we perfect these lungs. But yeah, I think there's a lot of fun stuff happening in the world of transplant.
Awesome. Thank you so much. Really exciting topic. We appreciate you having the time and coming in our webinar session. And for our audience, I think you saw the flyers. Please, be present in our lovely meeting at ATS, Airbnb, Bronchoscopy, and breakfast. Panels are great. Always for the fellows who are attending, we always have the fellows corner, so submit your request, and it's a lot of exciting topics and exciting speakers. And then we have a call for change with Dr. Badra and Dr. Zuleta and on Thursday, April 3rd. So stay tuned. Thank you, everyone.
Thank you. Bye-bye.